Thank you very much, Jackie.
Okay.
Over you go, Cass.
Okay. So I'm assuming that everybody can see the slides now and can hear me. And I'll just say next slide, Jackie, when I want to move on. So, yeah, thanks everybody for bearing with me there. I'm going to talk about the first study of my PhD, which is a systematic scoping review into clinical decision tools for the assessment of acceptance of chronic pain in adults. And I'd just like to note thanks to the studentship funding, which is Glasgow Caledonian and NHS Lanarkshire, also to my supervisors, Jo and Chris, and my many advisors, many of whom are here today. So next slide, please. So this is just talking about the background, and I think as the previous two speakers have highlighted really well, there's substantial heterogeneity within chronic pain from each of the sort of biological, psychological and social perspectives. So even if we just take the psychological perspective, there's many ways to kind of think about how we understand behaviours, cognitions, emotions, memories, factors such as fear avoidance in clinical practice and in research as well. And there's also considerable variety that exists in the approach and aims of healthcare treatments. And this may vary from aims such as pain relief through to improving function or quality of life. And there's lots of different ways that people will need to access this, if they can access it at all. So acceptance of chronic pain is recognised as an important factor in successful long-term management. And it was really my clinical practice, which is as a physiotherapist in chronic pain, that had it made me think about this further. So it's quite common in clinical practice to sort of have discussions about acceptance of chronic pain. And it will not be unusual for people to turn around to me and say, well, it's really all about acceptance, isn't it? And this also was highlighted as a theme in my master's research as well. So I was keen to take this idea forwards to the PhD. And what I was really wondering was, could acceptance of chronic pain be used in some way to sort of guide or inform clinical decision making around management choices for chronic pain? And this is obviously the subcategory of chronic pain, you know, where there isn't a sort of fix or a cure, where it's helpful to accept. So the idea was that a decision-making tool could potentially aid this in a similar way to like the Keel Start Back, which some of you might be familiar with. Next slide, please. So a scoping review was the method selected, and this can be used in a new field to map work that's already been done. It's similar to a systematic review in that it has a systematic search, but it's different from a systematic review in that it doesn't aim to produce a synthesised result. So the aim of this scoping review was to map and identify clinical decision-making tools that were based on acceptance of chronic pain in adults. And the Joanna Briggs Institute guidance was used, systematic database search was run, with 2 reviewers at screening and an additional grey literature search. And a protocol was uploaded to the Open Science Framework before the search began. Next slide, please. So the inclusion category was the Scottish version of adults. Chronic pain was the main sort of primary condition. That's not to say chronic primary pain. And so there was exclusion of sort of specific pathologies which may be painful, such as rheumatoid arthritis and haemophilia. And we'll probably all be aware as to actually how difficult it is to sort of tease those things apart. The definition of acceptance of chronic pain used was the broadest one I could find at the time. And the clinical decision tool, this concept was quite broadly defined. Before conducting the search, I was aware that there had been studies which had used the chronic pain acceptance questionnaire to identify subgroups of patients. So I was wanting to set up a definition that would include them. Next slide, please. So this is the PRISMA flowchart. So we started with 6335 through the database searches, an additional 6 through the grey literature searching, which was moved through screening to 19 articles that were assessed for eligibility at full text screening. And 8 studies were moved forwards to data extraction in the scoping review. Next slide, please. So at the data extraction, 6 were from Europe and 2 were from North America. The populations were mainly tertiary pain clinic populations. The one that wasn't was an online community sample in the US. There were no populations that were from primary care. The majority were women, and the mean age was in the 5th decade of life, and where reported, there was a significant majority that were white people. Next slide, please. I'm enjoying saying next slide. Next slide, please, a bit too much, I think. So 4 tools were found across the 8 studies, and there were different language versions of these used, actually. So the chronic pain acceptance questionnaire was one of the tools that was returned. This has 2 subscales, one of which is reverse scored. So the 20-item version and the 8-item version were both used. A further tool, which was called the Acceptance and Willingness Screener, which had 4 items, and the participant would select one of the 4 items that they felt best described their situation. And this was asking people about how consistently they could live life related to their valued goals. So I've categorised this lot under the sort of conceptual understanding of acceptance of chronic pain as an acceptance and commitment therapy construct. The other tool that was used was a 13-item Q-sort tool. So I'll talk about these in a little bit more detail. Next slide, please. So these are the main findings of the SPaRC studies. Now, this included 6 studies, and the studies sort of developed and built on each other. So 4 only used the SPaRC 20, and then the last 2 additionally used SPaRC 8 items. So the subgroups found that the initial 4 studies using statistical analysis developed 3 subgroups, and then the final 2 had 4 subgroups, and they termed these psychological flexibility profiles. So consistently, subgroups were found where both subscales were low, both subscales were high, and then there were some mixed subgroups within the middle. And there were correlation with other questionnaire scores. Now, what you're looking at here is a grid that was in the final of these studies. So you can see the 2 subscales mapped against each other. So activity, engagement, and pain willingness are the names of the subscales. And you cross-reference the scores, and the score lands in one of the 4 categories. So the idea here is that each of these 4 categories could indicate a different type of therapy need. So you're looking at a sort of stratified care model. So people with both scores low, this may indicate that they have a different therapy need than both scores high. It's probably important to point out that this hasn't been empirically tested, but this is the kind of idea of what the researchers were doing. Next slide, please. So the next one is the Q-sort. So this was a 13-item Q-sort tool. So there was a card with an acceptance statement on the top, and then it had a numerical value underneath. It was translated into Danish from an English study, which used a bigger Q-sort. And this is the only tool that was actually used clinically in a tertiary psychology clinic attached to a chronic pain service in Denmark. So the quantitative score was above average on the acceptance value. And what the author generally reported was that he found that sometimes the statements were misunderstood by people, or there were different perceptions of actually what it meant or what it was getting at, but that this presented quite a helpful way of actually discussing the topic and with regard to sort of what would be good to move forward with in terms of management. And sometimes that was no management, and sometimes it was, it was sort of further psychology management. So he categorised these themes, to include a turning point, unearthing of pain acceptance issues, and clear statements of self-acknowledgement that were not otherwise formulated. So next slide, please. So, discussion points. These are white Eurocentric tertiary pain clinic populations. No tools were found that were used in primary care, which is where most people with chronic pain are seen. The Chronic Pain Acceptance Questionnaire, the psychometric quality, including aspects of validity, has actually been found to be problematic by 2 systematic reviews of chronic pain acceptance based questionnaires. So that may cast doubt on whether I'd want to continue to use that. So placing it within the context of the qualitative literature, qualitative studies suggest that acceptance of chronic pain is actually quite a broad concept. So it can be described as a process, a state of being, a failure, an operationalized variable, a psychological construct, a lived experience, a whole world experience, a bodily experience. And these studies also report that the language and the meaning are difficult, and aspects of this can be open to misinterpretation. So this is suggesting to me that perhaps acceptance of chronic pain doesn't lend itself to quantification. And certainly indicates that there is a need to improve our understanding of what acceptance of chronic pain is, which has led me to my second PhD study, which is a meta-ethnography, which will ask what is the lived experience of chronic pain. So next slide, please. Okay, yeah, so I mean, there's a few references on the next slide, but I will take questions now, I think, that are not my own.
Well, thank you very much indeed, Cass, and for a very interesting presentation. Quite difficult to study it. Maybe I can ask something before we get anything in the chat. I can see Leslie's just put something on. I just wondered whether there were differences between the localization of the pain in different individuals. Did you measure extent of the injury area? Because that's potentially quite an important concept.
There would be nothing that I would have come across in those studies to suggest that there was an injury area, actually. I'm not quite sure what you mean by that.
The extent of the pain might make a difference, whether it's over a knee joint compared to a whole limb.
That would reflect my clinical practice, but that's not something that we'd looked at. I think within the studies, pulling out the correlation statistics, so like the SPaRC studies, this was measuring it using the SPaRC, which, as I've already said, is possibly quite limited. There was some correlation with pain intensity and the lower acceptance group.
Yeah.
So yeah, you could look at it that way, and you could take that away from it.
And Leslie's asking, how should we try and assess acceptance? Do we need a new questionnaire with involvement of PWLE?
So yeah, I mean, those recommendations are given in the 2 systematic reviews. I mean, I suppose what I'm really suggesting, and what I think was quite interesting with Liqueur, is why not listen to what the patients are saying and sit down and have a chat about it? Because as we kind of know, language is different and meaning is different. So if you're aware of what the concept means, then it's more thinking about how do you bring it up and how do you discuss it. I understand why people want to quantify it and why people want to measure outcomes and all the rest, but I'm just suggesting caution to that at the moment. I think with regard to what you're saying about the involvement of people with lived experience is really interesting. So that was not how the SPaRC was developed. It was developed from a sort of theoretical model. So the meta-ethnography that I talked about, that is a way of synthesizing and reinterpreting qualitative studies. So these are studies that have asked people with the lived experience of chronic pain and acceptance what their understanding of it is. And so the meta-ethnography will develop a new conceptualization of what acceptance of chronic pain is. And it's also noteworthy to say that I have 2 people with lived experience. Actually, I have 4, but I had 2 people who were invited on with the lived experience hat, and then it turned out that also clinicians on the advisory group of that also had chronic pain. So it's been really interesting to get their insight, even in just generating that sort of second study.
Thank you very much, Cass. We're going to move on. I see you've got another question, but unfortunately, Lorna Semple is asking something that
I'll catch Lorna later.
That's all right, Lorna.
Yeah.
I'm so sorry. We're a bit behindhand.